sanctuary zoo type thing where he would charge people to come in, and he's wild. He's like,
this is supporting families in your practice. We don't need to learn about that, do we?
Wild. And then there's other.
Good afternoon and welcome to session 3 of the NJAAP COVID-19 Q&A. In this ongoing series, our panel of experts are here to help provide attendees with the most current information on COVID-19 and answer questions related to those to the pandemic itself. Today's session introduces a new element to the presentation, and that is a presentation on a specific part of the many different areas to address within dealing with COVID-19. And today's topic, as you can see, is supporting families and your practice. It is being presented by Puthamanam Radhakrishnan, and Steve Carries was also slated to be on this particular presentation, but was called away at the last minute. So there will be this 15-minute presentation followed by a Q&A related to the presentation, and then we will move for the balance of the session to answering questions that have been submitted and will be submitted as we're tracking the chat box moving throughout. So if you have those questions, please present those. I'd also like to bring your attention again back to the fact that we're starting it out with a specific presentation. And we'd love to hear your ideas as participants in this Q&A session on what areas you would like to see the brief presentations presented on. And we would ask that you send those suggestions to covid@njaap.org. And now, without any further delay, I'd like to turn the session over to Dr. Radhakrishnan.
Thank you, Michael. So as Michael said, we want to introduce some of this going forward. And from NJAAP, we want to support you in every way that we can. And we found that a lot of questions were coming up with regards to the practice support. So we wanted to start off with that. And like Michael said, if you have specific areas you would like us to address and some people to address, please let us know and we will be happy to go ahead with that. Michael, I think you need to do it, Michael. I can't, that thing, my controls have gone. Next slide, please.
I've got you, bear with me here.
There we go. So this is just, Dr. Carey's had a lot of input on the slides and we made the presentation together, and I'm just gonna go ahead and present it for both of us today. All right, so can you go back one, Michael? Okay. So, you know, the changing landscape is that we have seen a sudden decrease in volume across the board. This is not only pediatric practices, specialist practices, the hospital, the inpatient volume, I'm sure all of you are aware, has significantly decreased to the point where a lot of the pediatric units have been repurposed into COVID units and other units for the hospital. And you know, we've come to a point where there's mounting uncertainty. We don't know what's going to happen tomorrow. We don't know when this is going to end, and we definitely don't know, you know, who's doing something right and who's not. But we're all trying different things, and the feedback is really important so that people know the direction that some of the people have taken, which seems to be working better for certain institutions as compared to others. Next slide. All right, so we're at a decision point. You know, do you make a temporary change in service? Do you change your business plan? Do you do well visits versus sick visits? Do you do both? Do you only do one? You know, there are a lot of alternatives. Do you start the telehealth services if you haven't already? And if you do, what are you offering on telehealth? What are the patients expecting? And, you know, when this all comes to an end, how do you go back to what you were doing? And do you go back to what you were doing? Next slide. Determine your personal comfort level. This is very important. There are issues to consider in your practice. There's a financial burden. We all know about this. When numbers go down, the amount of money you get in is going to significantly decrease. As with any business, unless you're providing the service, you're not going to get paid for it. And just on that point, so that I don't forget this, I hope all of you are aware of the programs that have been put forth by the COVID bailout, if you want to call it, whatever you want to call it, the CARES program, and the PPP, which is the payroll protection plan that was put out. And I hope all of you are taking advantage of that. If you have issues with that and you need more information, please reach out to us and we will be happy to send you some information too. Staff comfort level to work. This is very important. You may say, well, I want to stay open, but if you don't have a staff that can't support you, your practice is not going to work. At my practice, this is what I did. I sat down with everybody. We had a staff meeting. I said, is anybody here uncomfortable to work? Is there something that you specifically need that we can support you with? What is your comfort level coming to work? And that should be a huge part of how you make that decision of what you're going to offer, how you're going to offer it, and how much of it you're going to offer in your practice. You need to understand the environment that we're in right now, and your patients are not going to show up. Just the patients that you had made appointments for 2-3 months ago for physicals are the ones that are probably not going to show up. So you need to be able to reach out to them and confirm with them, are you coming in? Do you want to come in? Is there something you need to come in for? And that's the conversation you need to be having every day with your patients. Next. So communications are a huge issue in this day and age, and in the environment that we're in right now. Consider blogging. Set up a blog. It's very easy. Even if you don't know how to do it and don't have much experience with it, think about other people in your practices. If you have younger people, they are very, very astute and they know what to do about blogging. There are a lot of free blogs out there. You can set up the links to your websites if you have them, or just go, onto Facebook and put out your blog and tell your patients to link up from there. Identify a staff social media coordinator who can do this. And we all have younger, newer people who are coming into the practice who are very, very savvy on social media, and make use of them. This is the time to do it. And that's maybe a person you can identify and say, you know what, you could sit at home and do this, and that's totally fine, and we'll pay you. Email the patients, send the links, look at your patient portal. Most of us have patient portals, although the patients don't always sign up for them, but you could use that to basically send out e-blasts, just emails blasting it to every patient. We did that a few weeks ago, and even patients that had not signed up for the portal suddenly called back and said, you know what, I never signed up for that portal, but I think it's important now. Can you give me my links up again, or give me my password again, and do that. This is a good time for you to make, take good advantage of that and get people back onto your portals. Communicate your services and activities. What are you doing every day? How do you see the changes occurring? And make sure you update this. Just because you put something on this morning doesn't mean it's going to be true this afternoon. And if you have to change it, change it. Get back to the people who are doing your web. Maybe you do it yourself. Maybe one of their staff does it. And make sure you're updating things all the time. Go to the AAP website, go to the NJAAP website, see things that you think are important, and you can set up those links to connect your patients to it. It's very important. Next. So the key messages are, number one, immunizations. We have tons of questions on this. The point is, are you going to give immunizations? Who are you going to give the immunizations to? The immunizations are very important, and just because you're going to delay something doesn't mean that you don't believe in it, or your patients may question it. Why was it not delayed before, but now it's okay to delay it? That's going to be a question that comes up a lot. But the most important thing is those primary series. You don't want to delay that primary series. You want to get those kids in any way that you can, in any way, shape, form that you can. Whether that be that you do the preliminary visit on telehealth, and then you have them come in just for the shots, or you have them come into the office on a day when there's nobody else, or there's a schedule that you have situated around this, where you have well children under the age of 2 coming in at a particular time. Oh, go back. Okay. School readiness, that's another question that's going to come up as we come towards summer. A lot of schools have already told you that they're closed down for this whole term. They're not reopening till September now. So what are you going to do with those 4-year-olds that are going to need their shots, for coming for the fall session? So that's something you need to look at and get an idea of what you're going to do, get a plan ready. Post-COVID planning, very important. This is not going to be like this forever, or at least we don't hope that it's going to be there forever. So when this is over, what are you going to do? You have to have a business plan. Like you see all the big businesses, when they go into Chapter 9 or Chapter 11, they have what they're using as that time basically to plan for when they're out of bankruptcy. So the same way, we're in one of these positions where we're stagnant right now. We need to know when we get out of that hot water, what are we going to do? Or what is going to be our plan coming back to providing care for our children, for our patients. Next. So how do you execute this plan? Number one, make sure that you're interviewing every patient that wants an appointment, is calling into the office, and more importantly, their caregivers, because we do know that a lot of the kids are not getting sick from COVID, but they may be carriers, they may be positive, we don't know because we're not testing half of them. So the important thing is to interview the patients and their caregivers and their family, find out what's going on in their, in their life. How are they dealing with anxiety? Are the parents okay with the kids? Are the kids acting out now? Especially the kids, parents who have ADHD kids, they may be reaching out to you and not telling you everything. It's important then to go ahead and do that interview on the phone. Screen for appropriateness of an inpatient visit. A parent may call you and as usual say, my kid's got this thing going on, or it's got a rash going on, and I need to see you. You can offer them the alternatives that you may have available. Encourage virtual visits whenever they're suitable, maybe for a rash, maybe for a child just that has headaches. What are you going to do with the kid with the headaches? You're really not going to do much in the office. It's a lot of interviewing this patient, and even a hands-on neurology exam is usually not involved. It's basically just you can watch the child and have them go through the different things that you want to do that you would do in the office, and get a good idea of what's going on. And then if you still feel, well, you know what, I need to see this kid, give them an inpatient appointment, that's fine. But, at least get that screening done. It's very important. Next. Okay, pre-screening. Is there a fever? Is there a cough? Shortness of breath? Now, we know that most of the kids, a huge number of kids are calling in, or the parents are calling in for URI symptoms. And that could be that cough, the sneezing, the short, bringing up all that mucus, all that stuff. But is there a fever associated with it? Is that a cough really bad to the point with the shortness of breath? That's important to know, because that's your tick off, to say, well, I need to screen this kid for COVID at least. Are there rashes? And one thing important to remember is that always try to get these questions answered both by the patient and by the parents, especially when you get into the adolescent age group, the teenagers. They're hesitant to tell you that they've been sick. They may want to come in for you to check them out, but the important thing is for you to know what is their level of discomfort and how much is it important for them to come into your office. Is this something you can deal with on the phone? Family members and contacts, again, very important to know what their situation is. Is there a contact somewhere that maybe has developed COVID? Have you had a call from somebody telling you that, okay, they may have had COVID and you're a contact? It's important to get that history. It's very important. And always offer that virtual alternative. Right now, we're in that phase where telehealth is catching on. 6 months ago, we were all talking about it, but not a lot of people were doing it. But the point is that we're in that phase in our practices right now where it needs to be part of our armamentarium that we can offer. And it really should be a huge communication tool. And remember, everything that you could have done on the phone, you can do on that virtual visit. And at the same time, see the body language and see the patient at the same time. So that's very important. Next. Telephone this is just a sample of what you can do on the phone to get a few questions answered before you decide whether you want the patient to come in or you just want to do a televisit, or is this something that you just want to deal with on the phone. And as you can read, it says, hi, I'm from such and such a practice. I have a few questions for you before we can schedule a visit. Your answers will help us determine the most appropriate encounter. Are you calling for a well visit or a sick visit? You know, and we tell them presently we're offering well visits for children under the age 2 if you are doing that. And we particularly want to cohort them so they don't come in and get exposed to the sick kids. And if you are sick, we don't want you coming in at a time when well visits are there and exposing the well visits to this either. Next. Plan the day. You know, are you going to offer well visits on particular days of the week, or do you want to schedule them that you have a morning well and an evening sick, or a morning sick and an evening well? Do you have a large enough practice where you can separate the practice into 2 different practices? One side can be all well children, and they would see the kids, and the other staff and the providers can see, you know, the other side can see the sick or the well. So that's important to know. Consider the alternatives. You don't have to be open every day. And if you don't have enough staff, you can say, well, you know, I'm going to be open 2 weeks a day. I'm 2 days a week this week, but I am going to offer telehealth every day, you know, and put the telehealth patients on your schedule so you have an idea of what the day is going to look like for you. You know, I tell my front office staff that when you get a visit and it's going to be a telehealth visit, put it into my schedule and, you know, just shoot me that mail so that I know that there's a telehealth visit such times I can be available, and I don't schedule an an in-person visit at the same time. So, you know, that helps. Next. Other ideas that, you know, for this kind of time is group visits. If you're comfortable doing that, that's great. You can offer that on the Zoom platform. You can offer nutrition visits. You know, if you have adolescents that you want to talk to them about nutrition, at the same time, you can get a dietitian or a nutritionist in there. They can do that online. You know, just give the Zoom visit for that. Mommy and me time groups, and maybe you can get somebody who knows how to do exercise activity for children, young kids, or toddlers. And you can tell the parents, you know, well, we're offering this at 12 o'clock every day. You want to spend a half an hour with other kids also playing at the same time. You know, you're not going to be in the same room with them, but, you know, kids are seeing other kids, and maybe this will be a good time to get together and have that group-like activity. Next. Outreach, very important. I can tell you, talking about utilizing the EMR, I'm sure most of you were aware that last week the FDA pulled ranitidine off the shelves completely. So what happened? I'm sure all of us have kids that, you know, were, you know, had GERD, and we started them on Zantac, or maybe the GI started them on Zantac. Well, I was able to pull off my EMR every child that we'd ever given a prescription of ranitidine for. And doing that, I was able to get a list. I said, okay, these are the kids still on the ranitidine. We called the parents up. We told them we need to switch you off ranitidine, send the prescriptions to the pharmacy. It was a great outreach, and it was a nice way of telling parents, you know, we're still here. And if you have any questions, any concerns, please pick up the phone and call us. We'll be happy to talk to you. You know, talking to parents is very important. That way, it's communicating with them, telling them, reaching out to them, saying, you know, we're still here. So if you need us, make sure, you know, your medical home's being accessed. ADHD, autism spectrum kids, you know, these are kids who already have behavioral problems, and they're not going to their structured school environment anymore. They're sitting at home. You know, a lot of times it's one kid at home with no friends to play with. If they have other siblings, at least maybe they have some interaction. But, you know, this would, you know, a good time to reach out to those parents and say, you know what, if you need something, just pick up the phone and call us. And if I don't have an answer, I'll find it for you. Next. Structuring visits, separating the visits from well and sick, very important. And if you are going to offer well visits to the older kids, maybe you want to separate the toddlers and the infants out from them so they don't get exposed to them. Cohort the visits together as much as possible, unless you have that big an area that you can actually make 2 practices out of it at the same time. Choose a morning or afternoon, and make sure if you are choosing the morning versus afternoon, you're cleaning out all the rooms and making sure hygiene is being attended to by the staff also. Choose days for all sick or all well. That works well too. Emphasize patients 4 under 2 for immunization visits. Next. Patient communication. Counsel patients not to go to the ER. Our ER numbers are significantly down. I know that. Every pediatric ER in the state is going through this, where our numbers are really, really low. A number of pediatric ERs have actually closed up, and they're just being attended to by pediatricians in the main ER at this point. But you want to counsel the patients not to go to the ER. That's very important. don't expose children to things they don't need to be exposed to. And it's just a time and place thing. And it's very important to tell the parents about that. Encourage calls into the practice. We've always done that, I know, but it's to reiterate it, to tell the patients, you know what, it's even more important at this time. Maintain follow-up communications. Tell them, you know, I've done this where my hospitals send me faxes every day of patients that came to the ER. So this is not new to me. I've been doing this for the past couple of years already, where I have to sign off on every chart that comes in, no matter what the patient went to the ER for. And if I find something that I thought was inappropriate, I usually will pick up the phone or have my nurse practitioners pick up the phone or my office manager, talk to the parents, tell them, you know what, we don't think this was a very appropriate use of an ER visit. You know, if you'd picked up the phone and called us, you know, we might have been able to help you before you went into the ER. Do the same thing now. I do the same thing now. So if I'm seeing a patient go to the ER, that really shouldn't have been there. It's not, you know, someone who fell off a bike and broke his arm. That obviously was appropriate. But you got a kid, you know, their diagnosis was URI, no fever, no shortness of breath, nothing else, no medications, but the kid just had cold symptoms and the mom went into the ER. You know, I find it nice to pick up the phone and talk to the parents and say, you know what, we talked about this before. We'd really like you to call us. We're available. Please make use of us. You know, it's okay if you abuse us for this. That's fine. We appreciate it. All right, next. Well, this is the billion-dollar question, right? COVID-19, to test or not to test. First of all, is it available? Now, a lot of the commercial labs have set up testing for this, especially those of you who have done the respiratory viral panels in the past. Most of the labs have added the COVID-19 panel to the respiratory viral panel. So if you did the swabs, you can send that same swab in. But remember, if you're doing a swab with the understanding that this may be COVID-19, you should be making use of your PPEs, which is, you know, your gown, your glove, your eye protection, and make sure that you do that swab appropriately. Who will obtain the specimen? It should be somebody who knows how to use the PPE, you know, who's doing it appropriately, and at least you've overseen a couple of them. Make sure it's being done right. PPE is very important. The availability of PPE is, you know, of course, in question right now. But there are sites, you know, especially like Alibaba or, you know, other sites that are making things available. From the NJAAP, we're also trying to see what's available and where it's available. So please reach out to us if you need to. But this is very important. So if you really think somebody needs to be tested, and, you know, the government sites or the county sites or the hospital sites are still only testing people who are symptomatic. So you may find somebody that you say, you know, I really want to know this for whatever reason. Then you do have the commercial labs available. Next. Providing anticipatory guidance. How are parents doing? Reach out to them. You know, how is your child doing? I know you've had some behavioral problems in the past. Are you coping with that well? Is there something we can do to help you? Screen for stress and need for resources. Again, you did this in the office all the time when they came in, and we should be doing the same thing on the phone. Provide community resource information where we are their medical home. We need to make sure we're still doing that community resource information spreading out there as much as possible. Next. Maintain a healthy practice, provide essential amenities within the practice. You know, when somebody comes in, hand sanitize for them to sanitize themselves. You know, if somebody's really not feeling well, maybe a mask if you had an extra one. Maintain consistent communications, you know, all the time. Follow-ups are very important. Listen to the concerns of the parents or the caregiver. That's very important. You know, the time has changed and we're in a COVID environment, but our practice shouldn't change because of that. Encourage self-care and physical and emotional care. Next. Some of the resources for practice and families are listed here. So the other thing we just wanted to mention is that going forward, at least, you know, over the next couple of weeks, we want to bring some information to you about the mental health aspects of your support for the families and the practices. So not only for the families, what, you know, telling them about the hub or available resources within the community, but also for the practices. If you have people that are really anxious who are your staff, you know, where do they go for this? So we will hopefully bring you some, you know, interesting and important information going forward, but please, you know, do give us feedback on that. Thank you. Michael, I'm done.
Okay, so at this point, we can just move on to the questions. And of course, you can get those in on the chat box. The first question that we have here is asking, are there any recovery rates or statistics that can be shared? So of course,
Meg?
this is all opened up to our panel of experts to chime in
Yeah,
as well.
Meg or Peter, I think you guys can address that.
So this is Meg Fisher. If you look at that Hopkins website where they have how many new cases, they also have a on the right-hand side of that, they have the number of patients who have recovered, and it really is remarkably kind of uplifting to think of that number. We're talking about hundreds of thousands of people who have recovered. So remember, 80% of the illness is mild, and now with the realization that there are more asymptomatic people, it's probably even more than 80% that are actually either mild or asymptomatic. So a lot of people have recovered, and that Hopkins site is the best site that I know of. Peter, do you know of any other ones?
No, that's I agree with you. You know, I'm just looking at the numbers from other sites, like the state. Even the majority of people seem to, do well and do recover. It's unfortunate, obviously, the people who die, or get very sick, but it appears exactly what Meg said.
Thank you. And our next question is, please clarify if the virus is or is not transmissible when asymptomatic. I have heard it is from some and others say it is not.
I think most people think, this is Peter again, most people think it is transmissible from asymptomatic people. That's the rationale behind wearing the masks in public or in public places, because it's not to protect the mask wearer that much, but to prevent spread from people who may not know that they have it or are completely asymptomatic. So I think the current thought on the matter is that, yes, it is spread from asymptomatic people. Meg?
Sure, I'll weigh in. So I think it's a definite maybe, but now probably there is increasing information that asymptomatic people are PCR positive, that some of them even have, there's been some viral load detection. So the presumption now is that, yes, asymptomatic people can transmit. This is a very big reversal in the last few days. And I don't want you to think that we now think it's the asymptomatic people that are transmitting all over the place. We still believe that it's most transmissible when people are symptomatic, but it is. I think we have to now say we think asymptomatic people can transmit, and that's, as Peter said, that's the reason for masking everybody everywhere. That's all.
This is Larry Kleinman. As an epidemiologist, I would say the spread doesn't make sense if asymptomatic carriage and transmission doesn't happen. So in addition to the science, there's inference, and I think they're going to converge at some point soon.
And as a follow-up, since you both touched on masks, as far as sanitizing a mask, does putting it in a hot clothes dryer or using a hot iron sanitize the fabric between uses?
So there are protocols for sanitizing N95 masks. I'm trying to remember if they're on the CDC website or if this is something that our hospital developed. But there are several different techniques. One is there's a microwave technique. Remember, if you're microwaving a mask, you have to be sure there's not metal in it. There's also a putting it in your oven for a certain amount of time. There's a steam way to do it. There's ultraviolet that can do it. So there are a whole variety of different different ways. There's also hydrogen peroxide that's been used, and these are ways that have been shown not to destroy the integrity of the mask. So that is an important item. I just am not sure where I can tell you to go to get the exact details.
Yeah, in terms of I think the question was addressing the cloth masks that are homemade. I think putting it through, this is my own impression, but if you put it through a wash cycle at a sufficient heat, would probably sterilize, well, certainly get rid of the virus. It gets rid of most pathogens normally. And the other thing is, I'm sorry, is the bandanas and the cloth mask, you know, they haven't really been tested, and it's really dependent on the cloth. They're talking about, you know, a cotton fiber would probably be better. But again, they haven't really been shown. But again, it's to prevent the droplets from coming out more than from coming in.
Thank you. Here's one. What do you believe should be indications for SARS-CoV-2 testing in pediatric patients?
Oh, it's a tough one.
Well, a lot of it's going to depend on how available the test is in your area. Remember that in order to get the test, you are, at the moment, taking the child somewhere where the testing will be done. So you kind of have to factor that into it. The absolute indications are hospitalization, so that you can identify and cohort patients who are positive or not. And I mean, that would really be the main one.
The other thing is, you know, I think Meg's very right. In the hospital, of course, you know, you're testing basically because the patient's sick and that patient's admitted, which thankfully is not huge. But, you know, when you're doing it as an outpatient, remember, more often than not, it's not because the child is that sick. It's more often, you know, who's that child being exposed to? Maybe they have a grandparent in the house, you know, do they need to cohort them out? Do they need to quarantine them? So that's the reason for that. So it's not, in the children at least, as far as private practice is concerned, community practice is concerned, it's more so a public health issue than it is the child's own health.
Yeah.
Would you agree?
Interestingly enough, I've seen some patients that some places are testing kids if they're being transferred to other hospitals, even if it's not respiratory conditions. And I've had some patients for surgical reasons have been transferred with no fever, no respiratory symptoms, who've been positive for COVID, surprising everybody.
Yeah, this is Alan Weller. In addition to being president of our pediatric hospitals at Robert Wood, so some of the reason that they're testing some of those kids is because if they're being intubated in the OR, that does become a higher procedure. I just want to let folks know that we're seeing a number of kids coming in, actually adolescents, who are vaping, and that sometimes it's very difficult to separate vaping in related lung injury versus COVID. And we have one patient in the hospital right now who's very, very ill, who's suspected COVID and vaping. So I think just to let you folks know out there, if you need to really make sure that, especially when you're looking at the kids and the young adults who may be of vaping age, and unfortunately that's 9, 10 and above, is that if you get a positive vaping history, your threshold might be a little bit lower about referring them in, because we've seen these kids very acutely decompensate once they've arrived at the hospital. So just giving you a clinical pro and a clinical update for what we're seeing right now.
And the CDC does have a priority for testing, and I think we did a good job here of saying who should be tested. So priority 1 is for hospitalized patients and healthcare facility workers with symptoms. Priority 2 for the greatest risk of complication of infections, to make sure they're rapidly identified and triaged. So those are patients in long-term care facilities with symptoms. So that's either adults or children. Patients 65 years of age and older with symptoms, patients with underlying conditions and symptoms, and first responders with symptoms. And then you get all the way down to priority 3, is, as resources allow, test individuals in the surrounding community of rapidly increasing hospital cases to decrease community spread. You know, that'll only work if people, you know, even without testing, if people do the physical distancing, you would decrease the cases. So I think that's why that's all the way down at priority 3.
Mhm.
And non-priority is individuals without symptoms.
Thank you. And just a few questions about daily life, related to daily life. So I'm gonna lump them together. So if I go out to the grocery store, should I change my clothes when I get home? And is it safe to reuse the clothing? And if a member of my family goes to work each day, is he or she going to make us sick? Should the working person be isolated from the rest of the family?
Well,
Go ahead, Peter.
It's a difficult question. I'll tell you, at this point now, when I come home from the hospital, I certainly get rid of my clothes and take a shower on arriving home. And then my clothes do get, again, washed in a hot cycle, and I can wear them again. I don't know that I can afford to throw out every pair of clothes every day when I come back from the hospital. But some people are wearing scrubs and maybe doing that. I'm not sure that even if you go to, I guess my impression would be, unless your area is so the incidence is so high in your immediate area, you may consider something like that when you come home. But to take your, to shower and everything every time if you come from the store, and it shouldn't be often. Again, it should be spread out. Maybe a little much. I'm not sure, but again, it depends on the vicinity. You know, if it's a high incidence spread in the community, I think I would certainly consider it.
So I'll take a little different approach.
Okay.
I don't think we have evidence that clothing spreads this. You know, the droplets, we talked the last time about how the droplets last on different surfaces for different amount of time. And the nice part about clothing is the droplets actually get into the clothing and probably are, and you know, I'm saying probably, are not transmissible. So I think, I think if it makes you mentally feel better that you change your clothes and take a shower, that's great. But I think, you know, at least in my community here, with everyone out of work, they can't even afford to go wash those clothes at the laundromat so many times. So I don't think we should be making recommendations that are over the top when people can't do them. So do what you need to do for your own mental health, but I don't think that we have a lot of evidence or any evidence that clothes are important in the transmission.
Yeah, no, I think that's the point well taken. There's and this is this is almost anecdotal. There was a report I read this weekend where they they looked at environmental contamination within a room with people who had COVID, and they did a baby actually, and they found COVID on the bedding, on the railing, and on a table about a meter away from the infant, where the infant was staying. And that was where they think they put supply, like when they were feeding the baby, they may, or changing the clothes, they may have put them on the table. Or materials. However, very interesting, they looked at the healthcare worker and they looked at their PPE, including the gowns and the mask, and there was no virus detected on on the healthcare worker who's taking care of the baby. There was no virus detected on the PPE, including the gown. And this is after the healthcare worker actually fed the child, and by holding them. I thought that was interesting.
That's great news.
Yeah. They also did it in adult rooms, and they found the same thing. It just wasn't on the gowns and the PPE. but it was on contact surfaces.
Okay. Next up is a 4-year-old has had a high fever for 3 days, then recovers. Some diarrhea, but no other symptoms. No testing offered by doctor. Where does this leave the parents and 3-year-old sibling?
Pretty much the way they are all the time. So, you know, I think that for most infections in children, we don't actually make a firm diagnosis, or, you know, and we kind of live with it. It's just that this one is a little hard to live with. The one thing I will point out, though, you know, although we're saying now that asymptomatic people can transmit disease, there's still not a lot of evidence that it's going from children to adults. In fact, it seems to be going the other way, from the adults to the children, at least based on who ends up hospitalized in China and Italy. So I'm not, you know, I think, you know, they're all household contacts. So yes, it's possible that they're going to get the same illness, but I think that's about the best we can do.
Thank you.
And I think even when we have widespread testing, we're not going to be testing, I don't think we're going to be testing everybody with a cough.
Mm-hmm.
To you, Mr. Kyle. Okay,
Can I be
I'll start the
tested
next one.
for antibodies? If I have antibodies, does that mean I can safely work or volunteer in a hospital? If I have antibodies, does that mean I will no longer be able to spread the disease to someone else?
Hold that thought. We hope so.
Right.
We're beginning to get information. There is now a drive for people who have recovered from COVID to give plasma. There are studies using there are beginning to be a few studies using the plasma to treat infected patients. I think if the plasma proves to be efficacious in treatment, then we can definitely say that you're protected. We just don't have any information right now. We think it probably means you're protected, but you know, this virus isn't playing by all the rules.
Right. Yeah, there seems to be preliminary data, very preliminary, that sera, you know, convalescent sera is, you know, does appear to improve the situation, which, as Meg said, certainly suggests that the humoral antibody, you know, can be protective. Just 2 points. I mean, when you're looking at the antibody, you have to be looking at show that it's neutralizing antibodies. You may make an antibody response to some antigen that may not affect clearing, possibly. The other thing is many viral infections are, the infection is mediated by cell-mediated immunity, probably more so than humoral immunity. That doesn't, of course, say that humoral immunity won't work, but I think still more has to be learned before we can be more definitive about that.
Thank you. When do we think PCR plus patients stop shedding virus? Are we reasonably sure that individuals are safe to go back to work after, say, 3 days symptom-free?
So I would say no. So it's 3 days symptom-free plus at least 7 days from the beginning of the illness. And then if you're a healthcare worker and you go back to work, you still have to be, you have to be afebrile every day, and you wear a mask for another week. So we're still not clear on duration, and PCR testing alone is not going to tell us that, because remember, the PCR stays positive even when there's not live virus there. So, it can stay positive for a lot longer than you're actually contagious, we think.
Thank you. All you, Mr. Kyle.
What advice do you have for the eventual reopening of schools? What issues do you expect children and adults to present with, and how can we as school health professionals address these concerns?
So this is Dr. Rad. So at this point, at least, we have no consensus on that because I don't think people have even thought that far down the line. We haven't seen any papers from AAP on that yet either. I just think it's too soon for us to be talking about that school outlook yet. What do you think?
Hi, this is
Peter?
Doria Vicente. Sorry, I got on a little late. I had internet issues. So I'm in direct contact with the NJDOE as I'm on the subcommittee task force for COVID. I'm in agreement. There's been no talk yet for re-entry into school. However, we are, it has been mentioned, and the guidelines are going to have to be rewritten for entry from the NJDOH in partnership. But I see there was a mention here about NJAAP as in partnership with New Jersey State School Nurses and the DOH on rewriting guidelines upon return to school. So as he said, it hasn't even been mentioned yet as far as when we're going back, but there's going to be specific screening tools and need for PPE and so forth. And we are keeping a list of that. So when that happens, we will definitely be letting all the school nurses know.
Thank you. So, follow up on asymptomatic patients transmitting the virus. Are asymptomatic young children thought to be less likely to transmit COVID-19 than adults?
I think Meg addressed that a little while ago. It appears that the transfer is more towards the adult, towards the child, rather than the other way.
And I did just,
This is Larry. Oh, sorry, go ahead, Meg.
I did just see a publication where they looked at viral loads in adults versus children, and the viral loads in children in that particular article were much less. But part of this depends which article you read. Go ahead, Larry.
Yeah, I was just going to say that a lot of the inference we make is epidemiological data, which it's hard to know because there hasn't been a lot of asymptomatic testing. If there's a lot of mild COVID around the kids and they're transmitting a milder form because of viral loads, or they're not transmitting at all, or if it's just that a large scale epidemiological picture, kids seem to be less of a factor in transmission, kid to adult than adult to kid. But we really don't have great knowledge at the individual clinical level what the risk from one individual child is.
Mm-hmm.
Okay, thank you. So this one is a little bit Greek to me, but I'll do my best to get.
Hello?
You lost your Michael?
Yep.
Michael, we lost you.
Okay, how about now?
Oh, you're
Yep.
back.
Okay, so this is where it becomes really evident that I only play a doctor in the office. But the question is, or the comment, ACOG recommends DC for SVD1 day and CS2 day. Please comment.
So this is Dr. Rat. We are doing this now, and yes, the AAP recommendations had been for an early discharge needs an early visit to the doctor's office. People are trying different things. I know some people have talked about using visiting nurses to go out and get the height and weight and the babies and do the televisits. Other places have talked about, having maybe a clinic where all the babies can come in and just get a height and weight and stuff like that. But yeah, these kids are going to be at high risk. We know that, especially when you have an early discharge. What are you going to do for the Billy checks and stuff like that? But I think in this environment, we don't have a choice. The less that we are exposing these moms and babies, the better off we are.
Yeah. Hi, it's Alan. At RWJ, we are discharging low-risk babies between 24 and 36 hours. It's really important to make sure that there is follow-up, and from our perspective, we're recommending follow-up generally at 24 hours, and in some exception 48 hours. And we are looking in our own practice, and that we have one of the Billy meters, so that we're able to assess the Billy levels if we can't get that done correctly in the hospital. You know, there is an increased risk for these kids, so there's a lot of pressure on discharging them from the parents, since the other parent is not allowed to stay in the hospital often. But we make sure we need to do this in a very safe fashion. So we do recommend and encourage that all these kids be seen and followed up at 24, no later than 48 hours to do all these checks.
And
So,
in
Alan,
our practice at RWJ, the outpatient practice, we are doing that. We have two primary care practices. One that's functions as a normal practice, a typical practice. The other is a community health center. We are scheduling patients on Saturdays and Sundays for the general practice, and Saturdays and Mondays for the community health center, with the general practice clinicians being available on Sunday for the other folks. So it is an outpatient burden, but I think in light of what's going on, it's relatively light lifting rather than heavy lifting, all things considered.
Yeah, this is Dr. Rad. So I have a comment on this because a lot of practices are following what we are doing, which, you know, what you just described, which is not seeing well babies every single day. So if you have a baby that's born on a Sunday and I'm not seeing well babies on Monday, it's not going to happen till at least Tuesday, and that's 48 hours away. So, you know, there are things we have to play with, and there are, you know, suggestions like if we have a baby that's a little higher risk, and, you know, we will pick up the phone and call the PMD and tell them, listen, you know, we have this baby we really think should be seen a little earlier. Can you do something, just make an adjustment or do something for that? And I think that communication is very important to make sure that the hospitalists are picking up the phone and calling the PCP, and not just telling the parents, oh, you know, make sure you call your PCP and get an appointment in 24 hours, because probably that's not going to happen.
That's a great point. This is Meg Fisher. I was on a AAP Echo this morning, and a doctor from New York City, where, you know, of course they're in the height of this, said that there are actually practices or hospitals where they will take the bilirubinometer out to the parking lot and check the babies in the parking lot.
Huh. Wow.
You know, people are doing amazing things.
Well, Meg,
Really?
the other issue is how good is this bilirubinometer? Because, you know, at my hospital, we used to use it, and we stopped using it 2 years ago because the discrepancies were too much.
Yeah.
Sure.
Yeah, Dr. Rad, just the ones that have come out in the last year or two are much, much, much better. So we had the same issues at our institution, and we picked up some new ones. They don't have the reusable tips. They're much more accurate, much more consistent. Just FYI for everybody.
Yeah, and they're certainly at the lower end safe to reassure. At the upper end, they probably don't discriminate as well and may require testing to confirm. The other thing for the situation that Dr. Rad noted, where people are cohorting patients, is neighboring practices can do a little bit of collaboration to try to cover each other for necessary checks in between. So if they're alternating days, this is a crisis, and we need to work together to come up to solutions that are safe and plausible.
Yeah, and this is Alan Weller from NJAAP president. So just to piggyback on that conversation, we had a phone meeting with the Department of Health, and one of the areas that we are looking at, and we have a meeting upcoming with Medicaid, is to change the situation a bit so that it allows more flexibility, and that your neighboring practices, that we're going to try to push them to allow Medicaid, to allow more of that sharing of patients, to allow these kids to get the needed care, because there are a lot of restrictions on what you as a practitioner can do if the patient's not in your panel. So we hear that, we know that, and we're making lots of movement with Medicaid to try to get that done, and we'll keep people posted on the status with that.
And, just to bring this back, I'm sure most people here are aware of the issues that we've had with VFC and Medicaid and practices. And this is one that really, really hurts us because we're finding that there are a number of practices in an area where they're not taking Medicaid anymore, or they're taking Medicaid, but they lost their VFC. And we're finding at my hospital that, we've got families who have 2 and 3 kids and they're going to a pediatrician, but all of a sudden that pediatrician said, well, I'm not taking Medicaid anymore. So you got to find somebody else for your newborn baby. This, I think as a community, we need to come together and do exactly this, help out each other.
Okay, here's one that's a little bit unusual that we haven't heard quite yet, but it's relative to those who are testing positive but completely asymptomatic. Is there a possibility of false positives? And to go further, is there the possibility of false negatives?
There's
Yes.
always the possibility in any test. No test is perfect. So,
And
yeah,
some-
there's always a possibility.
and I think as the rapid tests come into play, there may be even more both false negatives and false
Right.
positives. The false positives can be from misreading the test or from contamination from the last specimen. Remember, these are PCR tests. And just when you have a low incidence of disease, then you see a lot more false positives. Now, right now in New Jersey, we have such a high incidence that we're going to assume that most of the positives are true positives. But again, it doesn't necessarily correlate with viral loading and being contagious. False negatives can happen because it's a lousy specimen, because the timing's wrong. You're just a day before you before you had enough virus that it could be detected, or because the test was it was a faulty test or a faulty person doing the test. So yeah, there's both false positives and false negatives.
Right. You have to be concerned with the massive amount of tests that are coming in now to labs. They're really overworked. Certainly, there's chances of cross-contamination of tests, which would give false positives. So.
Thank you. I'm just going to jump in on another one here, Kyle, excuse me, but can you comment on the surgical mask level 1 versus level 2 versus level 3 for healthcare workers?
I don't, at least in our place, we're not using level 1, 2, 3. So I'm not sure what, I don't know what, I'm not sure what it's referring to.
Are you talking about biosafety levels?
I read the question exactly as it appears. I would assume that that's what it's referenced to, but. Maybe we'll take, there was another one that appeared before this that dealt with the UV. Let's see if I can recapture this one.
I did reply to that, Michael, the one about the use of UV to.
Right, I just wanted to make sure that okay.
Yeah,
And there's a specific protocol out of Nebraska. And I posted the link to that specific protocol, and that's the one the CDC references.
Yeah, just for folks with the majority of the folks who should be doing that are probably hospitals and using on N95s. There is real risk to using a mask if it's not done properly. So I do as Jean said, and we've sent out on the message board. Please be very careful before you implement a mask reusing process, and that you really understand what you're doing and how you're doing it, because you don't want to be in a situation where you increase the risk to yourself. The vast majority of interactions in the outpatient setting probably are suitable to use the regular surgical masks, and you shouldn't be doing nebulizers in the office at this point in time. So just really be careful of following those protocols.
Mm-hmm.
One of the real issues with re-sterilizing the surgical masks is that they often don't stand up to the actual material of the mask is broken down by steam, it can be broken down by temperatures that are excessive. So even Lysol spray can actually break down depending on what the mask is made of, if it's a simple surgical mask.
Okay, thank you, Dr. Kraft. Here we are at 1:59. There are other questions that remain open. We have captured them. I just want to remind everyone that in moving forward, that we're looking for those intro topics that you might want to have a little bit of more in-depth information on or covered a little bit more broadly. And so we are asking that you send us your recommendations on those topics. And again, you would just send it to covid@njaap.org. So on behalf of NJAAP, first of all, we'd like to thank our panelists for taking the time to be on the call today, answering the questions. Dr. Rad, we thank you for your presentation. And to those of you who participated in session 3, thank you for joining us again. And we will be announcing more information on following subsequent sessions. So with that, I call an end to session 3, and thank you. And everyone, be safe and be well.
Thank you.
Thank you, Michael,
Two.
and everyone.
Everyone.
Bye.